Thank you, Allison. Well, welcome everyone to this webinar today, an opportunity for us all to learn a little bit more about the Affordable Care Act, consideration for school behavioral health programs in rural communities. We have a lot of different people from across the country that are joining us today, many of them from state offices of mental health or education, state offices of rural health, as well as a number of community behavioral health service providers. So we hope this will be an opportunity for you to learn from our presenters as well as to ask questions. We'd like for this to be interactive and allow you an opportunity to get some of your questions answered. I'm myself, Jennifer Kitson, I'm a senior training and technical assistance specialist for a long name for a national PA center, the National Center for Mental Health Promotion and Youth Violence Prevention. I work for Education Development Center. The office is located in Waltham, Massachusetts, but I actually work from a rural part of the country in Kansas. And I will be moderating today as we hear from our presenters, Ron Manderscheid and Terry Lawler. So we want to talk about what the Affordable Care Act has in terms of implementation for school-based behavioral health programs. Of course, we're still awaiting decisions from the Supreme Court in terms of what the Affordable Care Act may mean. We do know, of course, that each state will be developing their own plan and that there are some core issues that Ron will be addressing for us in terms of preventive health care. So there are increased access to health care, we hope, in terms of not having exclusionary pre-existing conditions. There will be hopefully more children who will be able to access and utilize services and have easier availability for funding through health insurance exchanges, Medicaid and CHIP. We will be looking at health care primary home care, so there will be a primary home, and schools can be an ideal location for developing this integrated care system to provide prevention and promotion of services as well as care delivery. We'll be looking at, in this presentation, birth up to age 24 or 26, depending upon who's speaking at the time, about the behavioral health care strategies in place and the core competencies that are most critical to effectively working with schools so that we reduce health disparities, also increase social media access for folks, and have outcomes that are not only individual for the individual child and youth, but also for community outcomes. And then also looking at the whole continuum of the IOM perspective from the promotion, prevention, through universal, selective and indicated interventions, as well as treatment, recovery, and resilience and population health. So we know there's a number of barriers that Ron and Terry will be helping us think about in terms of eligibility, getting a highly trained workforce that is knowledgeable of evidence-based programs, and also clinical care that looks at the school and community together. So I think I'm going to go ahead and introduce Ron and let him give us the perspective of what we might be looking at that would be most important to the objectives today. So our objectives are to engage you all in a discussion about trends in healthcare reform and implications for behavioral health, the significance of schools as the setting with rural communities for the provision of behavioral health, and provide participants with strategies and examples to successfully implement those programs in school and community settings. Many of you are already beginning to do that work now. Thanks, Allison.
Okay, we're going to do our first polling question. We have a couple before we get on to Ron, just so we can see the background of everyone here today. Our first question is, in what region of the U.S. is your community located? We have the Northeast, Mid-Atlantic, Midwest, South and Southeast. Our fourth choice is the Southwest. Fifth is West, Northwest Mountains. We have Alaska, Hawaii, and Territories. Of course, we only have 7 options. Otherwise, we'd love to have everyone in their own category. so far it's looking like a toss-up between the Midwest and the Northwest mountain area. Which of course is still a very big area. And we have 11% in the Northeast/Mid-Atlantic, 30% in the Midwest, 11% in the South/Southeast, 18% in the Southwest, 22% in the Northwest mountain area, and 3% in Alaska and Hawaii.
All right.
Great. Now on to our second polling question. What is your role in your program or community? First is management administration. Second option is clinician or service provider. The third option is family youth. Fourth is community-based program provider. And then we have other. It looks like we have a lot in other. Over half in management and administration. We have a couple in family youth and also in community-based program provider. And the rest looking like they're in other. We're changing a little bit. Oh, getting some representation from the clinician and service provider role. It looks like we have some, at least some representation from across the board, but mainly in management and administration, and then other. So on to our last polling question before we hand it over to Ron. How well do you understand the implications of the Affordable Care Act, the ACA, which is what will be referred to as during this presentation, for behavioral health in rural communities and schools? Your first option, I do not have many questions about how the ACA could affect my community. The second option is I have a basic understanding of how the ACA could affect my community and have a few questions. And third, I do not understand how the ACA could affect my community and have many questions. Of course, there are no wrong answers here. It looks like about a little over 60% are saying they have a basic understanding, and the rest of you do not understand how the ACA could affect your community and have many questions. So we're glad you are here today. So Ron, I'm going to hand it over to you. Please press *7 to unmute your line, and we have you on video.
Okay, you have me on video, and can you hear me?
Yes, we can.
Okay, excellent, excellent. So I want to thank Jennifer and Allie for organizing this session. I think it's very important that we talk about these things. What I'm going to do is some backgrounding, and then I'm going to talk about some features of the Affordable Care Act. And I guess to get out of the way in the beginning here, my opinion of the Supreme Court case is that it will not turn out at either extreme. It will not turn out where they turn down the whole thing, or it will not turn out where they approve the whole thing. It will be something in between, and what's likely to change is what's called the individual mandate. And we'll see. I also heard a presentation yesterday from a constitutional professor at Harvard who says the whole thing is constitutional and the whole thing will be approved. So we'll have to watch very closely to see how this turns out. So let's go to the first overhead here.
And I hate to interrupt you, Ron. This is Jennifer, but I wanted to introduce you so that people know your background. Sorry. Just want to say, because you've done a lot of work in this area, and as serving as the executive director of the National Association of County Behavioral Health and Developmental Disability Directors, your association represents county and local authorities in Washington, D.C., and provides a national program of technical assistance and support. You also concurrently are an adjunct professor at the Department of Mental Health, Bloomberg School of Public Health, Johns Hopkins University, and president of ACMHA, the College for Behavioral Health Leadership. Dr. Manderscheid, you've also served on the boards of you do serve on the Employee Assistance Research Foundation, the Dania Institute, the Frameworks Institute, the Council on Quality and Leadership, and the International Credentialing and Reciprocity Consortium. You also serve as co-chair of Coalition for Whole Health, and previously served as the Director of Mental Health and Substance Use Programs at the Global Health Sector of SRA International, as well as several other federal leadership roles in the U.S. Department of Health and Human Services. You've always emphasized and promoted peer and family concerns, and you also were the branch chief, Survey and Analysis Branch for the Federal Center for Mental Health Services, CMHS, at SAMHSA. During the Clinton National health care reform debate. You also served as Senior Policy Advisor on National Health Care Reform in the Office of the Assistant Secretary for Health at the U.S. Department of Health and Human Services, and a member of the Mental Health and Substance Abuse Work Group of the President's Task Force on Health Care Reform. As such, you've continued to work in support of the implementation of the Affordable Care Act of 2010, and it's a very big pleasure for us to welcome you here today. Thanks.
So, Jennifer, thanks very much for that very kind introduction.
Yes,
probably too kind here. So I'm going back now to my first overhead, where I'm going to try to characterize some of the major things that are going on here. So one of the huge activities that I would call even a social movement is that we're moving toward whole health and person-centered care. And you see that in major efforts to move toward integration. You see that in major efforts to work on wellness and so on. And I think we need to view that as a major part of the context we're going in that will continue whether or not we have the Affordable Care Act. Also, my second point, which is part of the first here, integrated care is going to become ubiquitous whether or not we have the Affordable Care Act. And part of the issue here is how far will integrated care extend and what will be its relationship to service delivery systems in rural areas, and will it extend to social services and so on. My third point, integrated care is likely to extend to social services as we go forward. A huge change, I think, is moving from traditional managed care to benefit management through case and capitation rates, and I'll come back and say a couple more words about that as well. Service communication becoming virtual. Today, Facebook is a toy. 5 years from now, Facebook will be an essential tool in the delivery of behavioral health services. And then finally, a huge story, but we don't hear much about it, the vast growth of peer support in the behavioral health field and how peer support is beginning to emerge as a health navigation field as we begin to move into the Affordable Care Act. So these are all things that are going on, many of which will continue whether or not we have the Affordable Care Act. Okay, please go ahead here. Some demography. So if I look over the next 20 years, several things are going to happen. If I go back to the year 2000, we had 282 million people. We're going to grow to 350 million people by 2030. We're going to become vastly older, and I think this is a huge demographic change. Any demographer would look at this and say, my, what a huge demographic change, to go from 12 to 18% elderly in the U.S. So to put that in kind of perspective, instead of 1 in every 10 people you see being elderly, 65 and older, it'll be 1 in every 5 people. And translate that into numbers, you're talking about moving from probably about 36 million elderly people to 72 million elderly people. And that will disproportionately affect rural areas, which already tend to be more elderly than do urban areas in the United States. So I think that's something to keep in mind in terms of the delivery of behavioral health services in rural areas. We're going to become more racially and ethnically diverse, and I think that process is going on not only in urban areas but also in a lot of our rural areas as well. All persons with behavioral health conditions will come forth with personal health insurance cards, very different to the world that I grew up in, which is the world of block grants, large movement of federal money down to the states and down to providers, which will not occur that way. It will occur through the form of personal insurance cards. Huge growth in Medicaid and Medicare during this period. Medicaid currently has about 60 million enrollees. Expect that to grow to 80 million. Medicare has currently about 55 million enrollees. Expect that to grow to 75 million. And if you add those two numbers together, then you are at approximately half of the U.S. population. Okay, please go ahead. So some important logic here, I think, to think about is that the youth with the most severe problems are those in our communities who are most likely to already have some access to services. And I think a major question for that group is how do we improve those services that people already have? So they may have some services and not others. They may not have an integrated package of service. They may not have a system of care and so on. So I think a major question is what can we do to improve that, what I would call fairly shaky service delivery system? Youth who are near poor and less severely ill are much less likely to have health insurance or any access to services. So I think a major question, not only in rural areas but in urban areas, is how are we going to extend our service delivery system to reach that population. So to put all these numbers in kind of perspective, if you look at the population of youth in the United States, it's about 80 million. About 20% of those 80 million are the total cluster of children I'm talking about here. Only a small percentage of that total cluster of 20% of the 80 million children in the U.S. are those who get services currently. There's a much bigger cluster who don't get any services at all. And one of the important steps that the Affordable Care Act can take is to begin opening some doors for that second group to begin receiving services and for the first group to actually improve the services that are delivered. Okay? Please go ahead here. So again, some important facts on insurance. So we've done a very good job with the S-CHIP legislation in the United States. So before we had S-CHIP, where we stood was approximately half the children in the U.S. had private health insurance, about a quarter of the children in the U.S. had Medicaid insurance, and the other quarter of the children in the U.S., well over 20 million children, had no insurance at all. So what we've done, and we've done very well with the S-CHIP legislation, we have been able to decrease that number of children with no insurance to currently about 8 million children. And the S-CHIP legislation that's already in place should move into that 8 million and basically eliminate that uninsured group for the year 2018. That will go ahead whether or not we have the Affordable Care Act. So I think that's a very important thing to remember. I think another major feature here is that health insurance by itself is insufficient, and I'm sure most of you on the phone know that, being people who deliver services to children, that you absolutely must have social wraparound services for most of these children. And we're going to have to figure out how to build the relationship to those social services as we go forward here, not only for the most severe, but also for the less severe children. And then finally, and you know this in spade, rural youth are much less likely to have access to these needed services than our children from urban areas, and they're definitely much less likely to have access to any needed prevention or health promotion services. Please go ahead here. So some of the questions here that you then come to is how can you develop and implement disease prevention and health promotion services for all youth in your community, and how can you extend health insurance and behavioral health services to rural and frontier youth who don't currently have access to those services or have access only to inadequate services. Okay, please go ahead. So now I'm going to move into some what I call predictions for the whole service delivery system, including a little look at children in here, and then I'm going to move into a further discussion of the Affordable Care Act. So some of the big things. So if we look out to 2020, I would say by 2020, managed care is going to be ubiquitous. And what's going on right now is the major translation of the state Medicaid system from unmanaged systems to managed system, and almost every state has an 1115 waiver either in process or approved, or they are putting together an application to bring their Medicaid system under management. So obviously that one of the issues going forward for children and youth here will be how are we going to deliver services to children and youth going forward in this new managed care environment. and I think there has not been much experience with that around the child and youth population. And some of the things for you to think about, the actions here, beginning to think about a managed care solution for yourself. So how would you go about managing the benefit for children that you currently serve in your programs? How can you benchmark that against what other people are doing? So it's very important to be able to communicate with other people and work with them on these issues. And begin to recognize that managed care itself is going to become ubiquitous and probably will be done in a very different way as we move toward 2020, moving away from the traditional pre, concurrent, and post-utilization review to management through case and capitation rates. And don't really have a lot of time to develop that idea, but would be happy to talk with you further about it on another occasion. Okay, please go ahead here. Integrated care for youth services will become ubiquitous. So the concept of system of care is being modeled in many different ways. It's being modeled in what's called the health home. It's being modeled in accountable care organizations and so on. And as we move into the Affordable Care Act, you're going to see more of that, with the idea that by developing and implementing integrated services, you actually improve the services for the person. It's person-centered care because the person is brought back together. It's whole health care because it brings the various features of care that people need together. And it also saves money compared to operating many systems independently. So some actions for you in this area, become very deliberate about how you will think about integrated care going forward here. And so what I always would ask, if you were sitting in a room with me, I would ask how many of you are currently in the process of thinking about or actually working on becoming part of an accountable care organization going forward, an accountable care organization for delivery of services to children and youth. I think in that you'll have to assume that behavioral health entities will not control the accountable care organizations based on experience we've had in the field with CMS on this issue already, but you will need to be part of accountable care organizations in order to participate in the evolution of systems of care and health homes going forward here. And a key part of this obviously will be paying attention to quality measures, because accountable care organizations imply you will be accountable for the care you deliver, and the state government and the federal government will be watching the outcome measures that occur in performance measures of those programs. Okay, please go ahead here. Another major change, and I alluded to this earlier, is moving from a system that focuses almost 100% on care delivery to one that also includes as an essential part of its service delivery package prevention and promotion. And if you look at this in terms of money, currently about 96 cents out of every dollar is spent on care delivery and only 4 cents out of every dollar on prevention and promotion. The goal is to move that from 96 and 4 to 70 and 30. So if I were sitting here in the year 2020, I would be saying we're spending 30% of all of our health care dollars on prevention and promotion activities. And that implies an important distinction, again, that I think we have not paid attention to in behavioral health care. We have only served people who came to us with behavioral health problems. We have not served people in the community who don't currently have any behavioral health problems, including children and youth who don't have any behavioral health problems. So this is going to require that we start thinking about behavioral health in a much broader way than we have, and beginning to think about our outreach into the community in a much broader way than we have as well. And so some of the actions, you need to begin thinking about some new products that offer prevention and promotion services. You also need to start thinking in population and community terms rather than just in clinical terms where you think about the individual client. So what are some prevention, disease prevention, and health promotion interventions that can be delivered at the population level and at the community level in in addition to the more traditional work that you do at the clinical level. I also think another process that's underway is literally moving from the office out into community. I had the occasion to be in Texas yesterday, and I was in a place called Victoria, Texas, and I was meeting with the regional behavioral health center there. They are literally in the process of getting ready to begin to do outreach to health clinics in the schools. And a major part of that is moving their operation out of a very large building where they sit now to have at least part of their staff work directly in the community, where you don't have people come to an office, you go to the people in the community, you go to the people in the school, et cetera, et cetera, et cetera. Very vast change from the way that we have done this in the past. Okay, please go ahead. Now I'm going to move to the Affordable Care Act and look a little bit about how the Affordable Care Act will influence the insurance of children and youth and the service delivery to children and youth, including in rural areas. So the Affordable Care Act has 5 pieces: insurance reform, coverage reform, quality reform, performance reform, and information technology reform. It's a 2,300-page bill. 2,000 of the 2,300 pages are about insurance reform and coverage reform because they both deal with money. The other 300 pages are about quality reform, performance reform, and information technology reform, and those areas are all assigned to the Secretary of HHS to implement, and you've already begun seeing regulations coming from the Secretary, new programs. The Health Home State Plan amendments for Medicaid are a very good example of a quality reform effort that the Secretary has already begun, and so on. So in our work here, I think it's important that we say, and look at each of these 5 pieces and ask the question, how do each of these 5 pieces relate to care delivery to children in rural areas? So let's go to the first overhead here. Next overhead. Okay. So in insurance reform, there are 2 sides to insurance reform. One piece of insurance reform is the expansion of Medicaid to cover every single person in a state who currently does not qualify for Medicaid but is at 138% or less of poverty. And this is going to vary dramatically from state to state. For example, in Utah, they estimate that the uninsured population that will be covered this way is about 190,000 people. In Iowa, by contrast, where Iowa has a much less well-developed Medicaid program, they estimate they have 1 million people to cover in Iowa. So these numbers are going to vary dramatically. The significant part of this for our discussion today is that this mechanism can be used to enroll not only the parents who are in this population group, but also their children in the SCHIP program. So if we have parents who are at 138% or less of poverty, and they are parents of children who are living at home in the appropriate age ranges, those children will be eligible for SCHIP enrollment, and this mechanism can be used to enroll those children in SCHIP. So this is a way to accelerate working and penetrating that population of 8 million children I talked about before who currently do not have health insurance. And I would predict that there are many more such children in the rural areas of the United States actually than there are in the urban areas, because I would argue in the urban areas they've done a much better job of actually already enrolling children in SCHIP. But this insurance expansion through Medicaid will create the mechanisms to allow the enrollment of these children in SCHIP. Very, very important thing to begin thinking about and strategizing how you're going to do that. And I think to help understand that, I have the feeling that in behavioral health we do not know much about the uninsured population in our community because we've always worked downstream. We've worked downstream from the point where the person comes in for care. We haven't been concerned with the front end of the system. How does the person get insurance? What kind of insurance do they get access to? How does that insurance give us access to care, et cetera, et cetera? Now we're going to need to become concerned with that. So I would be recommending here in your rural areas to run some small focus groups to discuss and begin discovering in a better way who are these children who are currently uninsured, and how can this new mechanism through the Medicaid expansion be used to enroll these children in SCHIP. Okay, go to the next overhead. The other part of insurance reform is the state health insurance exchanges. That also will go live on January 1st of 2014. This is another mechanism for enrolling uninsured children. So when this mechanism is intended to do several things. So everybody who's at 138% to 400% of poverty will get a federal tax subsidy on their insurance, including on a family insurance policy that includes children. And the intent of this is that we can eventually someday say in the United States, we don't have a single person in the United States who doesn't have health insurance because they cannot afford it. If you're above 400% of poverty, then you will not be eligible for the subsidy. So this mechanism being set up here is one that will include insurance policies for individuals, but it will also include insurance policies for families. This is another thing you need to look at in your own area. How is your state working on state health insurance exchange right now? And it ranges from excellent. My poster child on state health insurance exchanges is California, to states that are doing absolutely nothing. And a lot of the states that are doing absolutely nothing are waiting for the Supreme Court decision. If the Supreme Court decision does not go their way, I believe that if they started right now, they could not possibly have their exchange up and running by January 1st of 2013, which is what the law requires, at which point HHS will step in and create a health insurance exchange for that state. And again, I don't have time to develop that idea, but it's an important idea for you to understand what's going on with the health insurance exchange in your state, how is behavioral health involved in this, and how is it focusing on the health insurance needs of children in your state. Okay, next overhead. Some new coverage mandates, and you will have heard about many of these things. So an important feature of the Affordable Care Act is that it says starting on September 23rd of 2010, no child under the age of 19 can be excluded from insurance because that child has a pre-existing condition. That's already in effect. On January 1st of 2014, that will be extended to all people of all ages. A huge, huge gain for people who have pre-existing conditions and disabilities. The other thing that's important here is family insurance will now, and does now already since September 23rd of 2010, extend to children up to the age 26. Why is that so important? We know that most behavioral health conditions begin in the teenage years. Most care begins in the early 20s. We also know this is important because under previous law, when you got to the age 22 and you were no longer in school, you could no longer be on your family policy. Very important right now because people coming out of college who are age 22 don't have jobs. 60% of the college graduates of 2012 do not have jobs. This insurance extension is a godsend to those families whose children are between 22 and 26. Another important feature of this is that all children who are in foster care are included in this insurance expansion, so insurance is continued for them up to age 26 like it is for other children. An important feature of this that I want to bring to your attention is what's called the essential health benefit. The platform benefit in the Medicaid expansion and the platform benefit in the state health insurance exchange will be what's called the essential health benefit. Mental health and substance abuse are required pieces of that benefit, and they must be provided at parity. And I'm involved in the Coalition for Whole Health. We have actually designed a model insurance benefit that we're now rapidly sharing with the states, and we're also sharing with state coalitions for whole health to get it into the dialogue at the local level to try to improve those benefits going forward, basically. Okay, next overhead. Moving now into quality reform. Health homes are going to become very ubiquitous by 2020, not only health homes for adults, but also health homes for children. And to me, that's kind of the next generation of the system of care that I know you're all very familiar with. And it will include, as I said before, not only care delivery, it will be integrated, will span behavioral health and primary care. It also will include prevention and promotion. So we need to begin sitting down and working very hard to think about how we're going to put these things together. And I think for you in rural areas, part of the issue will be how much of these services will be able to be direct, how much of these services will need to be virtual, where you're going to need to be sharing these services across counties and so on. I think one of the trends in counties, I guess I'm much more sensitive to that now than I used to be, is counties beginning to share their service delivery system. We have a lot of examples of that in rural counties in Ohio and Iowa who are beginning to share, and there may need to be a lot of thinking about creating these health homes and these accountable care organizations across multiple rural counties. Okay, next overhead. One of the points I want to make about the Affordable Care Act here is that we are not simply going hat in hand here. And by that, I mean we have a lot to offer to the table when we go and talk about health homes and accountable care, and we talk about getting S-chip insurance for children and so on. So we can actually offer the concept of recovery, which we could not offer 10 years ago. Virtually no other chronic care field can offer that. For children, we can offer the concept of resiliency. We have pioneered in the concept of resiliency, and the systems of care and the work that's been done, and excellent work done by SAMHSA around children, points to resiliency and well-being as being a major protective factor as you become a teen and an adult for the onset of other disease. And we also have peer support and family training to offer here. Again, many other fields don't have any of this, so I simply want to point that out. Okay, please go ahead. Payment and program performance, we can become very short about this. My prediction here is that we're going to move from the kind of encounter-based payment system we have right now, which is very costly to implement and difficult for providers to execute, to a system that's going to be an annual case rate or an annual capitation rate. CMS wants to move all Medicare and Medicaid money to case and capitation rates by 2020. As you move into this, you need personally as a provider to do a better job of managing your own benefit, and you need to also make the move from a focus on simply the individual client to the community and to the population, and begin thinking in a public health way, the way a public health provider would, about how you can work better with the population at an earlier point to prevent downstream illnesses from actually occurring. So I think that's going to become a very major trend as well. Okay, please go ahead here. So we talked about case and capitation rates. Some actions you can take on case and capitation rates, which are just absolutely essential no matter who you are or where you are. You need to begin having financial records that are good records so you can actually understand what you pay for care currently. And this will be very important. It will also be very important to be able to incorporate outcome measures into your work so you can see what the effects of the work you're actually doing are over time. Not only clinical outcomes, what happened to positive and negative symptoms and functioning, but outcomes in the community. Most family people are most concerned about what are the outcomes in the community. And there's a lot of work needed in this area in the field. and then start thinking about prevention and promotion care outcomes. So if you actually do prevention, are you able to prevent adverse childhood events, for example? Are you able to prevent the effects of adverse childhood events? A lot of thinking, a lot of interesting work that needs to be done in this area. Okay, please go ahead here. Health information technology, the Affordable Care Act assumes that you already have electronic health records. So that's a problem for us in behavioral health care because you know and I know that most behavioral health providers do not have electronic health records. And you also will know that we were excluded from the legislation that provided Medicaid and Medicare money to facilitate that. We are working on legislation to change that. We hope to have that legislation in place and passed by the end of this year, but obviously there are no guarantees. If we're able to do that, we should be able to bring about $2.5 billion to the table to work on this problem for all mental health and substance abuse providers, whether you're urban or rural. In the meantime, you need to look down the street. So if there's a local hospital that has an electronic health record or a personal health record system, you need to figure out whether you can participate in that and begin getting experience in using electronic health records. You need to begin understanding what CMS means by meaningful use criteria for electronic health records. So one of the things would be, are you actually using your electronic health records to do e-prescribing? That's one of the meaningful use criteria in what CMS calls its level 1 criteria. So I'm simply sensitizing you here to this world is also changing, and you need to think about it. And then finally also here, you need to become engaged in social media. And social media is going to be very, very important in rural areas. The role of cell phone use in communicating between providers and teenagers, as an example, or the use of cell phones or iPads to communicate health messages of various types. The best and most recent example of that I've learned about, there now is an iPhone app that you can have on your phone. If you have a problem with alcohol consumption, the iPhone app will warn you when you are near a bar as a tool to help you, adjust your behavior appropriately. So we need to do a lot more work in that area as well. Okay, next overhead. Okay, so I finished my presentation. I guess Jennifer or Allie, are we going to do questions now, or what is your druthers?
Yeah, we're going to do questions now. Thank you, Ron. That was wonderful. We actually have a question submitted through the Q&A box, so I will read that out first. And then once, Ron, you're done answering that, we'll see if there's anyone who has it through the phone line. Okay. So the question is, what if the community is a frontier area where neighbors might be miles from each other? Also, a lot of rural frontier areas do not have reliable access to technology. What then? So what then?
Okay, so a couple of responses here. So I did a lot of work on rural and frontier areas and concepts and looked at distances and so on when I was in the National Institute of Mental Health and in SAMHSA. And so when you have a rural area that doesn't have access, and I'm going to use West Virginia as an example, a good example of this. So in West Virginia, they have mountains. The traditional cell phones don't work in West Virginia because of the mountains, and the cell towers don't reach there and so on. You need a different solution. The state of West Virginia did not have any funds to develop a solution, so I did some work with them a number of years ago when I was with SRA, and what I encouraged the state of West Virginia to do is actually to work with Walmart. Walmart had a wonderful IT system that extended over the whole state. And Walmart has 60 operations in different places in West Virginia, which gave them very broad IT connection over the whole state. And you need to come to out-of-the-box thinking about some of these problems, such as how are we going to get information technology out there. And so in your state, it may not be Walmart, it may be somebody else, it may be Home Depot or whatever, but there are other solutions, and, I myself would be happy to talk with whoever had the question further about other solutions to that. In terms of service delivery, I use my Victoria, Texas example. Victoria, Texas has had wonderful experience with telemedicine. And with wonderful experience with telemedicine, your provider can be literally anywhere. Your provider doesn't even technically need to be in that state. And we're working on reducing the barriers between states so providers in one place can serve people in other places. So as we do that and as we improve that telemedicine technology, the provider literally will not need to be in the frontier area to serve people there and to serve them very well. What we'll have to do is create the platforms in those rural and frontier areas. Another important tool here that occurs to me is to use the Department of Agriculture Cooperative Extension Service, which extends into virtually every county of the United States, to begin creating that platform to make it possible to do this. So, again, these types of things require, in my opinion, thinking outside the box and not simply saying because I don't have it in this physical place, it isn't going to be possible for me to do this. So I encourage a lot of creative thinking. I don't want to be totally a prima donna or way out there, however, so you also got to tie that thinking with some, realistic possibilities of how it's going to be paid for. We're trying to get the $2.5 billion to help do that, basically.
Ron?
Yeah, please, go ahead.
This is Deborah Fickling.
Deborah, how are you?
Good, how are you? Hold on, I'm going to pick up.
I'm not talking about West Virginia is one thing, but I was thinking you were talking about going out into the community. What if your community has miles between farms? I like the idea of the rural extension service.
Oh, the agriculture extension service.
Yeah.
Another thing I've been doing a lot of work and thinking about recently is what is the role of the local community and the local culture in working on this? So even though there's miles between those farms, I will bet you those people get together for various events of various types in some of these local. Where do they get together? And I myself have participated in some of those events in New Mexico, so I know that you do that there.
Right.
How do we take advantage of the strength in those local communities to make it possible to do these things?
Right.
And I can't sit here in D.C. and do that for you. You got to do that out on the ground and understand the culture and understand how the community is structured, understand the different cultural traditions, the Indian tradition and the Mexican tradition, Spanish tradition you have there, and how they interact, to create that community. So I don't think there's an easy answer to that, but I also don't believe it's virtually impossible.
All right. And I guess the thing I objected to more was this whole technology reliance, because it's only now are the more far-flung areas actually getting the infrastructure.
Right.
I mean, they barely have it in the rural areas, and I know that it's really challenging. I know people who still use dial-up. So I think a lot of the school-based clinics, which I think are a great platform for maybe providing health care. I know it's one thing Mexico's looking at is using that more, seeing how they can expand the access to that more.
Right.
But I'm just concerned that we're getting too, I get a lot of email and I see, apps this, technology that, and there are places I know in New Mexico and probably in other areas where they just don't have wireless access. They don't have access to cell phones. You lose you drop, you're traveling through a place and you drop it. So I guess I'm just concerned about the reliance on technology when, we've been using telehealth for years, so that's, we're already there, but as far as other things, as far as basing things on applications, and I'm just concerned about that.
Make a comment about school health clinic here to say just a word about that, and then we probably need to go on in
Yep.
terms of time here. So the school health clinic. So in Iowa being very rural, a little bit like New Mexico, but maybe not quite as rural, the state of Iowa undertook the work to lay optic fiber cable to every school and to every library, public library in the state, so that they had began putting infrastructure in place, and the private companies were glad to lay the optic fiber cable and hope that they would get the business of, actually filling the technology in. The school health clinic is a very important tool of reaching not only children, but also of reaching families, and a couple examples in D.C. where actually family outreach clinics were created in the local schools because it was recognized that there was need not only to work with children, but also to work with their family members. Where you have those schools, and if you can put the technology into those schools, it's another way of doing it in a simpler way than saying I have to have it in virtually everybody's hands, at least initially here. So I think there's some positive things that can be done there, but I will grant you immediately that we have a long way to go.
Thank you, Ron. That's really great. We had several questions entered through the Q&A box, but in consideration of time, we need to move on to Terry's part of the presentation. However, for those of you who have entered a question, I am going to put them into a list so that I can send them to Ron. I'm pretty sure I can get your contact information, and we can just have that sent out to everyone so that your questions are not going unrecognized. So now we're going to move on to Terry Lawler.
Okay. So thanks, Sally. This is Jennifer again, and I'm going to introduce Terry. She's going to talk to us from the perspective of being on the ground, trying to do work with schools and mental health agencies, collaboratively working together to address the needs of children from birth up through the transition from high school. The Safe Schools, Healthy Students initiative is a federal cross-agency collaboration among the U.S. Departments of Education and Justice and Substance Abuse and Mental Health Services Administration, which was launched initially in 1999 to respond to increased school violence and the factors that would address violence, substance use, and mental health and behavioral needs. So these, since 1999, more than 365 communities in 49 states have been provided with an opportunity to put together resources and work that develops safe school environments, work towards promoting mental health and social-emotional learning from early childhood through graduation. So they're promoting the resiliency and well-being, as well as preventing and reducing suicide, substance use, and other mental health and behavioral concerns. They work together to provide mental health services both in schools and in the community, connecting children and families to those services. And they work towards really integrating that in a way that allows them to sustain once they no longer have this funding from the department. They monitor and evaluate the implementation process and targeted outcomes. They use evidence-based programs, and they create system change that helps to sustain these services after federal funding ends and to creatively work on strategies to fund the services that are needed by folks. So I'd like to introduce Terry Lawler, who is the project director of one of those Safe Schools, Healthy Students initiatives. She's in Hot Springs, Arkansas, a very rural part of the state, and she serves not only as the project director, but as the school mental health services supervisor. She is from the education world, originally as a teacher, as well as a counselor, principal, and assistant superintendent. Terry has done a wonderful job of connecting to the local resources as well as to her state agencies to basically put together promotion, prevention at universal, selective, and indicated levels, and treatment, as well as the resiliency services that are needed in the community. So Terry, I'd like for you to, I guess we're going to do a polling question first before you begin.
We are, and I will introduce that. Our first question for our last question for everyone is, how much is your community or program using a collaborative team, which could include school staff and community providers, to coordinate and integrate mental, emotional, and behavioral health services in schools? Our first choice is we include both school staff and community providers in our collaborative team. Second choice is we include either school staff or community providers in our collaborative team. And third, we do not have a collaborative team but would like to develop one. And it looks like most people are saying that they include both school staff and community providers in their team.
That's great.
And that there are a few saying that they do not have a collaborative team but would like to develop one. So we'll leave some time for a couple more votes. And that looks like it's about our split. So, Terry, on to you.
Well, good afternoon, everyone. Thank you all for giving me the opportunity to share from Hot Springs, Arkansas on this summer day. I'll begin by looking at something that I think is very familiar to all of us, and that's the challenges that just doesn't face our schools today, but basically are facing our communities. And the bottom line is, unless we create a new system of enabling effective practices to provide services, no matter who the providers are or who the families or children that we are serving, then we're always going to be faced with these challenges. So how do we create a system that helps us to meet those ever-increasing challenges that you see there? Next slide, please. We learned several years ago that we had to change the way we practice. And when I say we, I'm talking primarily from a school district's point of view several years ago, but now I consider myself to have a much broader community, even statewide point of view. Several years ago, when we were in the business of education, we saw an increase in the number of children who were not learning up to their potential simply because of many of the social, emotional, behavioral challenges that they were bringing to schools that we had no clue what to do with. We had an inconsistent approach to problem solving simply because we didn't have the background, nor the knowledge, nor the resources to work in this arena. There were few ways we had organized ourselves, not just within the school, but in the broader-based community. So what we had to do is we had to figure out a way to bring together a plethora of services at the appropriate service point for those whose needs were very diverse. So that was the context of our challenge. Next slide, please. Unfortunately, when we work in isolation, this cartoon is too often true. Schools, welfare system, the judicial system, the mental health system agencies, when we work in isolation, unfortunately, kids and families fall through the cracks. And we come to a point when we're working in isolation that we realize that we just can't handle it all. We have to exclude or let go of some in order to take care of those that we really can take care of. Unfortunately, what happens to the children that we let go of is it usually perpetuates a cycle of continuous need. And we were tired of seeing that cycle almost overtake our community. Next slide, please. So let me tell you a little bit about our story. Hot Springs School District, small school district, 3,800 students. We have 8 schools. We're a large school district in terms of free and reduced lunch, which means that we have a lot of families who are living in low-income households. We have in our district an even balance between children of color and Caucasian. And we also, though, have really put a lot of emphasis on a higher quality of teaching and learning through our magnet elementary schools programs. And that's a little bit about our district, demographically and educationally. Next slide, please. So here's where we began our work. Hot Springs School District began by embracing the philosophy of coordinated school health. While we recognized that we were responsible for the education piece, we also recognized that we were only one component in that whole compendium, that whole wheel called the whole child, that while we were in charge or responsible for teaching and learning and cognitive development, we also knew that we had an influence on social, emotional, and physical, but we were perhaps not the best to do that. We also recognized that there were children who needed mental health services, maybe not in the instance where it was where they needed to be removed from the school, but needed some what we call Tier 2 or intervention kinds of mental health services, that if they were provided that little bit of support, would become successful students. So first thing we did as a district, we went and partnered with the state of Arkansas and the Department of Education, the Department of Health and Human Services, and the Department of Health. What we determined to do was to create a new system, a new way for all of us to come together, all stakeholders who really had a stake in children and families, working together to provide appropriate services at the best point of services by the best agency possible to do that work. In order to do that, we set up teams in each of our schools. We call them positive behavior interventions and support teams. And these teams basically were established in each school in our district. You can see the team members that were included there. All of those were required to sit in and be a contributing member on these teams. And I supervised those teams. We did the training, we did the organization, we did the staffing, and we did we set up those teams in order to meet together 1 hour each week, and we developed a process, including a mental health contract, including a procedures manual for all of the agencies, including a referral system that included the medical home or the primary care physician, and all, again, any and all stakeholders needed to wrap around that school and that group of students and identify their needs. That team put in place Tier 2 interventions, things like check-in and check-out plans for individual students. We put in targeted specific behavior, academic, and social supports, small groups, with our school counselors, with mentors, with faith-based organizations providing after-school programs. We have a plethora of Tier 2 supports, and I'll talk about those specifically in just a moment. But what we began to think of is what kinds of lower-level interventions do, quote-unquote, at-risk students need in order to prevent them from needing to have intensive mental health services, and we put those things into place. We thought about the children, and we thought about which agency and organization could best provide that service, either at school during the school day or after school away from the school setting. Where would that be? We also, through this group, did coordination of referral services to all kinds of agencies, nonprofit, profit, community, mental health, medical health, social services, anything and everything that you could think of families and children might need. We set up a referral system for those services to connect children and families to the right service at the right point of service by the right agency. And then for those children that needed a more intensive plan, and that tends to be about 5% of our student body right now, we developed what we called individualized coordinated school health plans, and we provided wraparound services plans. We actually wrote for a state grant with one of our mental health agencies, and so that mental health agency could manage that system of care grant, but those wraparound plans and services are provided most often at the school setting or in the home. So that's sort of an organization chart for our coordinated school health effort in the Hot Springs community. Next slide, please. This is our Hot Springs Middle School. It's just a picture of their pro-social plan. The green part represents areas that all kids get at the middle school. In fact, every student on Monday receives a social skills training. We call them Trojan Pride objectives. It's things about respect, responsibility, being safe, being healthy, taking care of yourself. They're like 10, 15-minute little vignettes to teach children the middle school level, the social skills that they need to know and be able to do to be safe and healthy. We also have implemented several bullying programs, not just Stop Bullying Now, but a whole bullying for us is a real serious. We've been very aggressive with that. We've also done some things with our reproductive health of our middle school students. So that's just a sampling of the kinds of programs in the area of social emotional supports that we provide for all kids. The yellow area is that Tier 2, those intervention kind of things. Before children get to that red zone where they need intensive mental health or any other kind of services, what are some things that we put in place to help those children to kind of steer them into a more healthy, safe person, but at the same time helping them on a long continuum plan. We provide mentoring, one-on-one and small group. We've done behavior plans. I mentioned check-in and check-out. That's where they have a coach, an individual coach that meets with them first thing in the morning to get them ready for school and last thing in the afternoon before they go home. We've done more intensive social skills training in small groups. We have students meet with their individual counselor, and again, after-school programs both at the school site, at the agency sites, at the community sites, at faith-based sites. And then I'm supposing the area that you're most interested in is the area where we've actually provided school-based mental health, individualized coordinated school health plans, and wraparound plans. But I can tell you this, if you don't do the green and the yellow, you will be overwhelmed by the red. That's where we were 5 years ago. 5 years ago, our triangle would have looked basically a lot of red, not much yellow, and a smattering of green. But what we've been able to do in the Hot Springs community is to decrease the number of students who really need school-based mental health services while providing more quality school-based mental health services for those kids who really do need it, but making sure that we have interventions and supports on all areas for all kids so that each and every child can excel academically as well as grow up to be healthy socially and emotionally. Next slide, please. So here's the essential elements that we found, and those of you who have done a lot of collaborative work with your agencies, I bet you have these too. I bet you found that your contract is your Bible. It took us 3-4 years. Last year was the first year I felt like we had a contract nailed down that was super beneficial to everyone involved, not just schools, not just mental health agencies, but actually students, children, and their families. And I think the contract was so fair in that we asked our mental health agencies to provide 70% of reimbursable and 30% pro bono, and because of the numbers of students that we were able to identify and get into mental health services quickly because we accessed the medical homes and we have their PCP as part of our partners, our mental health agencies were well able to maintain and establish full-time mental health teams on each of our campuses and make a profit, essentially a pretty good profit on a 70% billable. That 30% is so critical to us in our contract because that's where we get in some of those prevention and intervention supports. And frankly, we really had our mental health agencies were great because they had to think outside the box and look down the road and see how prevention and intervention were actually a part of their mandate, a part of their mission. And in doing so for our community, we actually could do a much better job of finding and taking care of children before they had to be removed from the home or before they became such behavior issues in school settings that they were not getting the benefit of a quality education. Another essential element is getting those parents involved. Because we had all stakeholders at the table who needed to be there, because we really went through a process of who is the best agency to provide this service, who's the closest in terms of that family understanding that this is what they need and this is what they feel comfortable with, and this is the agency person that can provide that, and where is the best point of service. Again, a lot of times it's in schools because that's where the kids are, but not all parents feel comfortable coming to school. School had to get over that. So we had to be flexible within our school day to find those pockets of time where the agency was actually in their office there at the school conducting agency business, not necessarily educational business, and making those parents feel comfortable about that. We started by developing a core management team. Our local school district superintendent, our Garland County juvenile judge, our chief of police, our local mental health agency director, president, CEO, our state mental health director for children's services, and a couple of other folks that were local, one a faith-based leader in our community and community development, and another a for-profit group that works very closely with the youth in our community. That developed our core management team. And I was the facilitator for that team, and yet we took turns facilitating those meetings so we better understood how each agency operated and worked. We took turns meeting in each agency so we would have a much better idea. I, being a school person, had no clue how mental health agencies really have to fight for funding. Mental health agencies had no clue how schools had no idea how to work with students on a day-to-day basis who had minor mental health or social emotional issues. So we had to understand where each other was coming from. And in doing so, we had to really walk in each other's shoes as much as we could. We also had to do some resource mapping. We also had to do some vocabulary, quit using our acronyms, and really begin to understand the language of each other's agency. We also had to be very flexible with each other's staffing. There were times when I allowed the staff of my school district to attend trainings and meetings in the mental health agency, with the juvenile judge, at the police department, at the local church who did nonprofit work, at the community center who does some for-profit work. They had to be excused from their daily task for me to go out and really collaborate in team, as well as the other staff coming into the schools and work. That was so energizing. That was one of the best things we could do. And now our staffs know each other by name in the community. We've gotten to the level where we can respectfully disagree and argue and sometimes rant and rave at each other, but understand that we're all there for the betterment of our children, that we're all working for the same cause. And so by identifying a school-based mental health team manager in each school, sometimes that's a school counselor, sometimes that's a school-based mental health case manager, sometimes that's the assistant principal, sometimes that's the dean of students, sometimes it's a person we call an intervention specialist, sometimes it's the school social worker. You've got to have someone in each school that has the job of managing that school-based mental health team and facilitating those in-school meetings. We had a parent support group. Instead of having several in our community, instead of each mental health agency having their own parent support group in the school, we have one now. All of our parents come together, whether they're identified at the mental health agency, at the school, whether they're identified at the DHS or DCFS, or whether they're identified at the juvenile court, wherever it is. we have one parent support group run by parents that all of us feed into, and they meet on a quarterly basis and do some really in-depth kind of support and training and information sharing while the kids are doing some fun kinds of stuff. And that has so helped bring our community together in terms of understanding how we can use our resources together to really support parents and how families can really be drivers of their own care systems. And then the other thing that we found was essential is you got to have a project director that gets it and that follows up, and it spends a lot of her time or his time working with the individuals in agencies and in schools and with families, just bringing the right people together and keeping them working together. So those were some of the essential elements of our services. Next slide, please.
Terry, this is Allie. I just want to give you a time limit. We have about like 5 or 6 minutes left for your part, so we can have time to get to questions.
Sure. Let's get that then. Here are some of our results. We increased our school-based mental health services. That number actually has grown to about 10% of our students, to where we have about 400 students who are now receiving school-based mental health services. The key there, though, is that they're the right students. Instead of a revolving door where we had mental health teams coming in and out of our schools and we never knew who needed to receive really school-based mental health services, our team approach is that we know which students actually need school-based mental health services, and they're getting it, and the students that just need some intervention and support are getting those. Next slide. That's just a compendium and year cost. Let me tell you, we really didn't need any money. We have enough children of poverty to support through the public health care system, which is fortunate for us. We have a Safe Schools Healthy Students grant, a lot of money, which does fund my salary. But I can tell you, you can do this without money if you have a committed effort in your community to do so. And I don't mean to say without money, period, with the money that's already out there existing. You don't need a huge grant to do this. You can take the monies that you have right now and make this happen. Next slide, please.
And for the next slide, this is Jennifer. Can you hear me?
I can.
All right. So for the next slide, I'm going to ask Terry to, with these bullets that you have in terms of tips for success with school behavioral health, just like you to consider, given the challenges and problems that your Safe Schools Healthy Students initiative identified in your rural community of Hot Springs, Arkansas, and then the successful work that you've been able to create for cross-sector collaborative teams that have done coordinated and integrated mental, emotional, and behavioral services in your schools. First of all, what infrastructure and capacity have you developed that will facilitate delivery of services to those maybe not currently eligible for Medicaid or not having private insurance or CHIP, but who may be eligible for managed care with the Affordable Care Act?
Thank you. I think the main thing we've done is to build our team. We have the primary care physicians. We have a local nonprofit who does medical work for underserved children, especially undocumented children. And we just made a concerted effort to voice the fact that if we work together, each and every child can become safe, healthy, and well educated. And we've bought into that as a community team, and so we've decided together to work even on a very deliberate, explicit referral process where each and every child can be considered for the services that they need and then can be found to get to those services and or those services get to them.
Okay, thank you. And what are the foremost critical features that were important to the system you've built, supporting children and youth birth through age 18 in Hot Springs, along with that continuum of services?
Well, you've got to communicate regularly. A lot of not just meetings, but a lot of individual one-on-one. That one person in your community that drives this effort, whether it be at the school district level or at some other agency level, that person communicating regularly with each of the entities and their staff members, and then bringing those teams, whether it's your core management team, your focus group, whatever you want to call it, together on a monthly basis to talk about what's working, what's not working, challenges, barriers, and how to address those. I think the other thing you have to do is you have to identify needs and gaps for service delivery. In our community, a huge gap was our undocumented children, a huge gap. We have about 15% of our children in the Hot Springs School District that are undocumented. That is a huge percentage. A lot of children that need services, not just mental health, but all kinds of services. And you really have to have think outside the box of how to, not in a non-threatening way, to anyone politically or to those families, provide those services. That's walking a tightrope. So it's making sure that you coordinate the resources. Faith-based is important. Nonprofit is important. Government is important. Schools important. Mental health agents. There's not a stakeholder that's not important. It takes us all coming to the table to do that.
Okay, thank you. And I believe it's time for questions. Is that right, Allie?
Yes, it is. And I have one question that was submitted, and I think this could go to Ron or Terry, but correct me if I'm wrong. The question is, for this and other collaborative efforts, how do all of the collaborative members, including but not limited to healthcare providers, bill for services currently? And secondly, what will the ACA provide for reimbursement for healthcare coordination efforts? So we had two questions in there.
It seems like the first question might be something for Terry.
Yeah, and the second one is for me.
Yes, absolutely.
Okay, please, Terry.
With our population of approximately 70% free and reduced lunch, we can, with a caseload of about 35 to 40 children, probably, again, 75 to 80% of those are going to be on public health subsidy. And so through that public health subsidy, then the billing for those mental health services in the schools are provided. For the other children, we do a lot of clinic-based. We do have some children that are private insurance, and we do refer them to clinic-based unless the parents can't get them to the clinic. And then we do some pro bono, or we figure out, working with the parents in that clinic, a way to provide that service either through their primary care physician or through our school counselors. That's a little tricky. But we're fortunate in that we have a large enough public health insurance base that that's how we can fund our school-based mental health program.
Great. And Ron, do you want to answer the question?
Okay, a quick answer to that. There are a couple mechanisms. One is, I mentioned earlier, the Health Home State Plan Amendment, which is a Medicaid amendment that your state can adopt, and it can have multiple of these targeted on different populations. That Medicaid State Plan Amendment actually allows for the payment of care coordination. And 90% of the cost of that state plan amendment will be paid for by the federal government for the first 2 years of the state plan amendment. So one example. Another example is, I'm going to use the state of Illinois for this. The state of Illinois Department of Health is in the process of doing a solicitation from local providers, asking local providers to submit applications to do two things. And they're asking for the local providers to tell us how you're going to coordinate care, how we're going to pay you to coordinate care, And secondly, how are we going to manage care? And we're going to pay you to manage care. And by the way, we're not going to allow you to subcontract care management to a managed care entity. So there are beginning to be examples here of awareness and recognition that we actually have to pay for care coordination, or it simply won't occur. And a health home won't work unless we have care coordination.
Wonderful. Thank you, Ron. We have about a minute or two, so if anyone has a question on the phone, please press *7 to unmute your line.
Allie, were there any additional questions earlier that you mentioned?
There are several of them, so I'm going to have them be sent out because we only have about a minute or two.
Okay.
Since it seems like we don't have any other additional questions, we have contact information here. And then also, lastly, if you're still on the line to take this survey, and this will also be sent out with a follow-up email. And also, we'd love to thank Ron and Terry for doing such a wonderful job with the presentations. We really appreciate your time.
And also, this will be archived, correct?
Yes, it will be. And it should be about Friday that an email should be sent out to everyone with a link to where to access the recording.
Allie, I would encourage anybody who has comments or questions for me to send me an email, and I'll be glad to communicate with them directly.
Wonderful. Thank you, Ron.
Great. And I guess I'd also like to, this is Jennifer, just to thank the Rural Behavioral Health group that works on this webinar series, and be looking for other webinars that will be upcoming that are focused on working with children and families in rural communities across the country.
Thank you for letting us share our hot spring story to all.
Yeah, thanks a lot.
Thanks. All right.
Oh, very good. So we need to say thank you.
Thank you.
Thank you, everyone.
Thank you, Allie.
No problem.
Bye.